Thank you, Neeraj. Oh, there are still some people out here. Thank you for being here. In an era where even surgery is trying to be minimally invasive, it's only natural that the monitoring and anesthesia should also be every effort to be non-invasive. We'll briefly try to cover these aspects of non-invasive hemodynamic monitoring. The rationale is simple. If we believe patient needs monitoring, then we should turn non-invasive as far as possible. That goes without saying. Whether it is feasible or not in cardiac surgery, we will go along as we see. There have been a lot of dispute and a lot of discussion about the fact whether the monitoring that we do, it improves outcome or not. And there are various arguments given in favor and against. And the decision is still sort of against that the invasive hemodynamic monitoring does not probably improve the outcome. But can we really do without it? Of course not. It is our experience and common sense says that you have to have hemodynamic monitoring. If nothing else, it may or may not impact the outcomes, but it certainly minimizes the uncertainty about the hemodynamic status of the patients and postoperatively as well. And on most of the occasions, what we find is that it definitely helps us to avert a impending catastrophe if we catch the signs early. And trending probably is more important than an absolute value. And ultimately, it is the interpretation of the person who is looking at those monitors and how he interprets and how he reacts and how he intervenes is probably will determine the outcome. And of course, if you see the monitor where all the numbers look good, that's so reassuring. The ideal monitoring, we know that it should be non-invasive, plug and play, accurate, should be reproducible, should be real-time, dynamic, inexpensive, and should be easily learned without a long learning curve. This is how we can define hemodynamic monitoring. We started with the invasive monitoring, then less invasive monitoring, minimally invasive monitoring, non-invasive monitoring, and even now we are probably heading for unobtrusive monitoring. There are very subtle differences between less invasive and minimally invasive. Non-invasive, of course, means that we do not puncture the skin or do not cause inconvenience to the patient which he refuses to accept. The reasons for going non-invasive are, of course, very well known. There are complications which can happen, the iatrogenic ones, and of course, the problem of infections and things like thrombosis. This is how we can briefly classify hemodynamic monitoring. The invasive are, of course, well known, arterial line, PA catheter. The less invasive and minimally invasive are loosely defined terms. When we say you need arterial line and central line, then maybe you can call it less invasive. And when you can only do with arterial line without a central line, like in non-calibrated devices, maybe you can call it minimally invasive. And then non-invasive. The various techniques, and the topic for today is non-invasive. The various techniques or methods which are available for non-invasive monitoring are based on pulse contour analysis, and the three examples of those are volume clamp method, radial artery applanation, and pulse wave oximetry, which is PI and PVI. Then pulse wave transit time, impedance cardiometry, electrical cardiometry, endotracheal impedance metry, which not exactly is non-invasive. Peripheral venous pressure monitoring is also now attempted, then again is not really non-invasive, though you can call it minimally invasive. And non-invasive tissue oximetry as and when it happens, and some new things which are happening now are photoplethysmographic imaging and passive infrared thermographic imaging, which probably we'll be seeing in future. All our cardiac output-based monitorings are basically work on the principle of ventricular-arterial coupling, and the basic feature in these is that the stroke volume is based on arterial contractility, arterial compliance, systemic vascular resistance. All these four comprise the cardiac output. And the other aspect which makes it, for the sake of monitoring, the dynamic part of it, whether what is the impact of what you are doing, is based on heart-lung interaction. Pulse contour analysis, we will restrict ourselves to the non-invasive devices. Volume clamp method is based on photoplethysmography. This is actually, if you see in this picture, this is a simple clamp, and it works on the principle that you increase the pressure up to a point that the volume remains constant. And this pressure is then taken as the pressure, arterial pressure, and through various algorithms you construct a arterial line. The examples of this are ClearSight, which was originally Finapress, and then NextFin. Another one is CNAP. Radial artery applanation, which is basically works on a principle that the radial artery pressure waveform is a sensor. If you see in this picture, that's the one. It's a sensor which moves on the electromechanically moves on the artery and records the pressure. And then they work on proprietary algorithms to construct a pulse contour analysis, and in a non-invasive manner give you a arterial pressure waveform to estimate continuously the cardiac output. These are the two examples, the volume clamp method and radial artery applanometry. This is once again, as I mentioned, this is based on the arterial contour analysis. This is the act directly from the arterial line, and these are the two methods that I just mentioned. Apart from these, we also have few techniques which are based on electrical velocimetry, which basically putting 4 electrodes on the patient's chest or in the neck, and it works on the principle that blood is probably the most conductive of all tissues, and the movement of blood within the thorax with each beat can be gauged, and you can, this movement of blood is gauged on the basis of changes in resistance and impedance, which is captured by these devices. What are that? Okay. And on the basis of the calculation of impedance and resistance, then they calculate the cardiac output. The examples of these are bioimpedance, bioreactance, and electrical cardiometry. There are minor differences in bioimpedance and bioreactance. This basically is a issue related to the fact that impedance is actually a vector which comprises of 2 scalar dimensions, resistance and reactance. So resistance and reactance, 2 together, they comprise impedance. And it is also compared to what we see in our radios and transistors that we used to hear. This has been compared that impedance was basically like AM, and as it has improved, bioreactance is supposed to be one better than the impedance and more precise. That's a comparison as far as understanding is concerned. Then the electrical conductivity of the thorax, as we said, this is based on the 4 electrodes that we put on the patient's chest. The results are contradictory. Bioreactance has been proved to be more acceptable in cardiac surgery, but not actually outside the operating room in the ICU setting. The causes and the explanations are not very clear. But the factors which definitely affect the cardiac output monitoring based on impedance are, the pleural effusion, pulmonary edema, arrhythmias, electrical interference, or movement. All of them are going to affect the cardiac output monitoring, the cardiac output monitoring based on impedance-metry. Electrical cardiometry also does something similar, but what it tries to do is to check the RBC orientation in the aorta. During systole, the orientation is different as compared to during diastole, and it measures that and calculates the impedance and comes out with a cardiac output. And this is one example of cardiac output monitoring based on impedance, based on electrical cardiometry. This is a handheld portable device which can be used, and this has also been approved for use in pediatrics. The endotracheal impedance-metry is the same principle, but instead of putting the electrodes on the chest, it is actually put on the cuff of the endotracheal tube. Once again, this cannot really be called non-invasive. The pulse wave transit time method, what is called an estimated CCO, estimated continuous cardiac output, it works on the principle that it calculates the time between the appearance of R wave in the ECG and arrival of pulse wave at the finger, and is inversely correlated with the stroke volume. So this is actually a totally non-invasive technique. You need an ECG and you need pulse oximetry. But then again, the vasoconstriction, vasopressors, cold extremities, arrhythmias, all of these factors do adversely affect. We have recently tried to use the pulse wave transit time method in our system, and we are still working on it to see and doing the validation and comparison. It actually calculates basis on the ECG and pulse oximetry. It gives you the values of cardiac output and related parameters. Pleth variability index and perfusion index is again a newer way of looking at it, and it has been possible because the pulse oximetry has now become more advanced and has enabled measurement of PI and PVI. These are totally non-invasive ways of measuring recording the ECG, the pulse oximetry, and non-invasively the blood pressure, which can be now transmitted through the web anywhere on the patient's, whether it is for a doctor or in his smartphone or on any monitor. All these things are possible totally non-invasively. What is the current status? There are various papers which have appeared, but by and large, the current status of less invasive hemodynamic monitoring, there are a large number of publications, but there is no strong evidence which has appeared in their favor, either because they are single center studies or they are because of limited number of patients. The patients included in the study have been of heterogeneous cardiovascular derangement, so agreement is once again not possible. And one of the debates has been, what do you compare it with? What should be the gold standard? Is the thermodilution PA catheter, transpulmonary thermodilution, or echocardiography? And once again, there have been questions raised about the statistical tools used to compare the different techniques. The three non-invasive methods that we mentioned, the volume clamp, there is a good agreement as far as the trending ability and reference techniques are concerned perioperatively, and the results are comparable during cardiac surgery, during the hemodynamic disturbances in the cardiac surgery, but poor results were obtained after cardiac surgery and in ICU patients. The cause is they are so dependent on alterations in vasomotor tone that they are not really reliable all the time. Same is true for radial applanation tonometry method. The initial results are promising, but every study that has come out, they have said further confirmation is awaited as far as the acceptance is concerned. This meta-analysis, which was published in 2014, probably is the being meta-analysis is it included all the studies available till then, 919 patients. Most studies had, though individual studies had small sample size. Out of the 28 studies, 20 were conducted in the operating room and 8 were conducted in the critical care setting. The CNAP device was the most frequently evaluated and followed by other techniques. And all of them, this meta-analysis concluded that the inaccuracy and imprecision of continuous non-invasive arterial pressure monitoring devices are larger than what was defined as acceptable by association for the advancement of medical instrumentation. So the limitations of these techniques, volume clem method does not work very well when there is peripheral edema or severe vasoconstriction, and radial artery applanation tonometry, there are issues related to the quality of signal impairment as the arm moves, so they are movement sensitive. Pulse wave transit time method, the estimated continuous cardiac output shows basically the conclusion was that what it gives is the unacceptable disagreement on what you find. Future, probably pocket size 2D and 3D ultrasound, functional images by electrical impedance tomography. The most promising thing that can happen is that we probably can collect hemodynamic data from different sources and do their intelligent post-processing and come out with some kind of a conclusions, and collectively can probably understand it better and then give out a approach which will work out to be better for patients. So as we are moving from invasive to less invasive to non-invasive, the next probably would be unobtrusive, where you just don't touch the patient at all and everything is done from a distance. And some of the things which are happening in this area are photoplethysmography imaging and infrared thermography imaging. And these techniques will probably, in due course of time, as they get further developed and refined, we probably may be able to pick up things like heart rate variability, BP-dependent pulse wave velocity, and even facial expressions, which will probably tell us about the patient's stress status and pain-related variables. This is how it may somehow look. A distant camera which captures the temperature, and some of the images which will appear like this and will read out for us as to, but this of course is future, and we at the moment are calling it unobtrusive. Let's see when it actually comes around what it is going to be. So what is the actual potential and rightful place for non-invasive hemodynamic monitoring? This is an exciting development. These innovations are really, they hold promise, but probably it is unfair to compare them in totality with invasive devices. Currently, it appears that these devices may not work when you need them most. Cardiac surgery will continue to need invasive devices, and these devices, the non-invasive devices at best can complement the invasive devices. And probably the correct place for these non-invasive devices would be to minimize invasion in time. So what they can help us do is to move towards less invasive era. And what they can do, actually, they will add value in high-risk non-cardiac surgery patients. That is one area where probably they can really add value. You need not start with invasive monitoring in the beginning. You can have some of these non-invasive monitors. They can sense early warning signs of the impending trouble. You can probably, based on those, you can guide timely appropriate measures and avert requirement of going more invasive, provided you catch it in time. So that probably we will have to see. At the moment, we are still in the process of comparing it with invasive devices, but I feel this is what we can do. They can complement the invasive devices. Thank you.